Hello, I am Dr. B.V. Rao of Usha Clinic and owner of the websites qmedicaldoubts.blogspot.in and drvagwamedicaldoubts.in. Today I am going to discuss about lower esophageal problems like hiatus, hernia of esophagus. Esophagus is a muscular tube from the mouth to the stomach. Upper end of the stomach in the chest, it is closely related to the aorta, left main bronchus and left atrium. It has two sphincters, one at the junction with the pharynx and the lower at the junction with the stomach. The musculature of the upper part is striated and at the lower part is smooth. It is lined with the squamous epithelium and glandular elements may be at the lower end or as islets at irregular points along its entire length. Esophageal hiatus hernia. The esophageal hiatus is the most important opening in the diaphragm through which herniation of abdominal viscera into the thorax can occur. Normally, gastric contents does not reflux into the stomach. When there is herniation of the esophagus, gastric junction, there is a reflux of gastric contents into the esophagus. It may lead to esophagitis. The herniation can occur at any age, but is common in the middle-aged and elderly. Types. First among them is paraesophageal hernia, or it is also called a rolling hiatus hernia. Here, a knuckle of stomach herniates alongside of esophagus through the hiatus. The cardiac esophageal sphincter remains competent, and below the diaphragm, even in extreme cases when most of the stomach rotates to follow herniated knuckle into the chest. Complications. A large hernia in the posterior mediastinum will lead to cardiac arrhythmias and breathlessness. Occasionally, symptoms become acute due to the obstruction, distension, or gangrene. Treatment. In acute phase, emergency surgery is required. Otherwise, it can be operated by planning. Esophagogastric or sliding hernia. In this type, the esophagogastric junction herniates into the thorax and there is a free gastric reflux. It is the common type of hernia. Clinical features. Reflux esophagitis, a deep burning pain, retrosternally more on lying down and relieved by sitting. It is related to exercise and radiates to upwards and left arm. Once stricture develops, the pain diminishes, but swallowing becomes difficult. In absence of these, the hernia is symptomless. Occasionally, there is frank bleeding due to the development of an ulcer in the herniated portion of stomach. Treatment. Reduction of weight of obese patients. Meals should be small and well masticated. Women should avoid corsets and tight garments. Should sleep in semi-upright position. In acute stage, antacids and bland diet as last diet is recommended. Correction of anemia with oral iron preparation. If not responding, surgery may be required, which includes repair of hernia, reconstruction of valve mechanism, and acid reducing procedure. Concomitant duodenal ulcer. If still not comfortable, resection may be necessary. Traction diverticulum. It is usually due to the chronic inflammation. like tuberculosis. In related lymph nodes, the most common site is the anterior wall of the esophagus, just below the level of bifurcation of trachea. By the time it is discovered, the incidentally during barium swallow, the disease in lymph nodes is healed. It seldom causes symptoms and treatment is necessary. Pharyngeal pouch. It begins as posterior bulge of mucus which enlarges to form a sac that extends downwards and to the left between the esophagus and the cervical spine. It develops at the inferior constrictor of pharynx. Usually formed sac causes dysphagia. There is swelling and gargling or of in the neck on swelling. May complain of reflex stridor or inhalation of contents of the sac. May lead to pneumonia. It may be due to congenital weakness of inferior pharyngeal constrictor. But its late onset and dysphagia precedes the pouch formation indicates the condition is due to muscle incoordination. Treatment. Treatment is surgical. A one-stage resection of pouch with careful suturing of its neck to take steps to prevent mediastinitis. Achalasia of the cordial spasm. It is a motility disorder of the whole esophagus which shows progressive atony and dilatation. Cause may be due to failure of nerve conduction due to the diminution of number of ganglion cells. In South America, Chagas disease with same findings is found with the infection of trypanosomes. Clinical features. Dysphagia with a little discomfort, feeling of obstruction behind the sternum, putrefaction of the residual food leads to an offensive smell in the breath, pulmonary infection due to silent inhalation. Diagnosis. X-ray chest shows enlarged esophageal outline with the fluid level behind the hot shadow. Barium swallow shows the dilated atonic esophagus coming to a stomach pointed termination, absence of gas shadow in the stomach. It has increased liability to carcinoma of lower end of esophagus, which makes the initial endoscopy essential and periodic review advisable. Manometry. It is helpful in diagnosis. Esophagoscopy. The removal of retained food facilitates the inspection of the walls. Its termination studied, bogies passed and biopsy taken. Treatment. Treatment is dilatation or cardiomyotomy. In dilatation, both bogie is passed through the lower end of esophagus and distensible bag guided through the narrow segment. Using water pressure bag is forcibly distended to split the circular muscle of esophagus. Cardiomyotomy, Heller's operation. Here the muscles at the lower end of esophagus and some distance above and below is split to expose but not penetrate the mucosa. Diffuse spasm of the esophagus. It is probably caused by disorders of Auerbach's plexus. Often there is hypertrophy of the muscle wall of esophagus. Symptoms: pain precipitated by eating and emotional stress. The pain is retrosternal and radiates to back, neck and arms. Diagnosis: established by barium swallow, which shows a holdup of barium in the esophagus due to the multiple uncoordinated contractions like corkscrew. Manometry confirms the lack of coordination of peristaltic wave. Treatment: educate the Educate to eat the adequate mastication. Nitroglycerin may relieve pain. Usually, conservative treatment may be sufficient. In young patients, cardiomyotomy may be required. Carcinoma of esophagus. It occurs in males of advanced age associated with smoking, spices, and alcohol. Common site is the lower third of the esophagus. The lesions are ulcerative and extends circumferentially and longitudinally in the wall of esophagus. Invasion of surrounding structures and lymph nodes is common and squamous celled in nature. When the adenocarcinoma is present, presumed to originate in the stomach, to invalidate the lower esophagus. Clinical features. Progressive dysphagia, intermittent and slowly regular form solids to liquids. Diagnosis. Radiology, obstruction and narrowing of esophagus. Esophagoscopy, repeated biopsy may be required to obtain confirmation of diagnosis. When stricture prevents the passage of esophagoscope, the passage of brush through narrowed area and examination of the dislodged cells is of value. Treatment. The chances of cure is less than 10%. In squamous carcinoma of upper and middle third of esophagus, high voltage radiotherapy is the treatment of choice. With tumors of lower third of gastrectomy offers best hope. Both methods may improve the survival rate. That's all about the problems of lower esophageal defects. In the next video, I will discuss about something else. Thank you.